Well, I think my concern with midwifery at the moment is it links actually with the shortage of midwives that we have. We're about 3,500 midwives short. And to me as a midwife, I think that I can't see the government actually taking this situation seriously. I don't feel as though that, I feel as though the situation is probably getting worse rather than even staying static. And what worries me about the shortage of midwives is that the impact it has on clinical care, the impact it has on health outcomes for women and their babies. As midwives, we've been saying for a long time now, we're shortage of midwives. Our shifts aren't being covered properly. Midwives themselves are being asked to come in and work extras just to be able to keep the status quo. And all the time we've said, this is going to impact on women's lives. This is going to impact on babies' lives. And we felt as though we haven't really been listened to. Apart from actually now I feel as though because things are happening in the clinical area, and problems are occurring, then we are now, I think, starting to be listened to. And if I can just, Leslie, read out something to you. So this is, we have confidential inquiries in maternity care, and that's so that we can, if a woman dies, we look, in detail at the case, and we try and find out, well, what went wrong. And we do the same with babies. So babies who die either before they're born as a stillborn baby or die very soon within a week or so after the baby's been born. And so this is the perinatal inquiry in front of me here. And this is something that's written by the President of the Royal College of Obstetricians and Gynecologists, the President of the Royal College of Midwives, and the President of the Royal College of Paediatrics and Child Health. And this is what they're saying. They say, however, the underlying issues, an overstretched and under-resourced maternity and neonatal workforce and changing population demographics also need to be understood. This report highlights how heavy workload and staff capacity issues can affect the care provided, leading to delays in transfers to the obstetric unit, plans for induction of labour being postponed, and difficulty in providing some elements of advanced life support when a baby requires resuscitation after being born. So we've now, this is hard fact, this is a whole report that's basically saying babies are dying. Babies are dying because we haven't got enough midwives. You can't get away from that. That's not just about midwives saying they're busy on a shift. This is about babies dying because of the situation that we're in. And there's, the staff shortages and the few midwives that we have, obviously it impacts on midwives themselves, their working environment, their morale. They end up being exhausted. And actually what we're finding is that midwives are leaving early. They're retiring much sooner than they once did. I mean, a midwife would go on till she's 60 or 65, quite easily. Actually, that's not happening now. We're having people not happy in their job, and so they're leaving, maybe at 50, 55 or maybe a few years later than that. And so therefore, we're always going to be losing those midwives. And those midwives actually are the most, the most experienced. So if you lose a midwife with 30 years experience, well, you might replace her with another midwife, but you might only be replacing her with a midwife for 2 years experience. So it's not the same. So even when people are saying, oh, well, we can get new midwives, actually those new midwives aren't the same midwives as the ones that you're losing. So I think that's the biggest problem that's going to hit us. So no matter what changes we want to bring in or new initiatives or different ways of working, you can't get away from the fact is there actually aren't enough of us. I've seen many changes in the last few years actually in maternity care, and one that's quite kind of stark really in the last couple of years is the fact that midwives now don't receive a bursary. Student midwives don't receive a bursary. Now, we've known for the last about 5, 6, 7, 8 years that we've had less and less students who were actually applying to become a midwife, to become a student midwife. So we've had less applications in. But in the last couple of years, we're about a quarter down in nursing and midwifery for the applicants that we once had. So, as I've said about, we've got a shortage of midwives, but actually now we're going to get a shortage of midwives that are actually coming into the profession to train. So that's been a big difference. And obviously that, if a midwife now, a student midwife now has to pay for a degree, you're certainly excluding a big chunk of the population, a big chunk of society that, can't afford to take on a loan like that. Or maybe they've had another degree before, and they can't take on another loan or anything like that. So you're excluding some great, I think, people who could make wonderful midwives. And so therefore you're not being fair. You're not allowing, anybody who wants to be a midwife, you're not allowing that to happen. So I think the bursary is one big change that we've seen recently as regard for me being an educator. So there's been a lot that's been happening recently, government policy wise, and its impact that it's having on maternity care. So there's been lots of things. So there's better births, for example, is a big agenda that the government are pushing. One is it's been going on for 2 to 3 years, and I actually don't really see anything particularly changing. So I think probably what they're actually wanting, I'm not too sure how feasible it is anyway with continuity of carer. So I'm not seeing a great deal. The big thing that concerns me is what they're wanting is the actual the money that's involved. So what's happening is women are given a personal budget of £3,000. Now what they're saying that the reason we're doing this is because it empowers women. It'll give women more choice, but actually, women have choice anyway. So they are met when they're first pregnant, and they're given choices. They're given choices throughout the whole of their pregnancy. I don't see how giving somebody money, which they don't physically get the money, it's just kind of something an amount that they can spend. But to say to them, this gives you more, empowers you more, gives you more choice, I actually don't think in reality it does. But what it actually does, and it's, I wouldn't say it's clever as such, but it's quite kind of underhand. What it actually does is it makes people start to think about the fact that, actually, let's see how much things cost me. So when my £3,000 runs out, or, a scan is costing me that much, well, actually, I'm in work, I'm fairly well paid. So actually, I will have those other scans or something like that, or I will have this additional care. So again, it's marginalising people. So women who don't have the money to top up their maternity care will not be able to, because they haven't got it. So therefore you're getting two different types of care given here. You're giving more beneficial care to women that can afford it. And the £3,000 anyway isn't enough really for a normal birth as such, or a normal pregnancy. Now, what happens then when things go wrong? What happens then when, a woman needs more care in her pregnancy while she's giving birth? What happens when her baby needs to go to special care? But actually, she's used up all of her £3,000 early on in the pregnancy because she's chosen to have additional scans or things like that. So it gets really complicated. Two, it's just not necessary, because as far as I'm concerned, we've all paid into the NHS. We've paid already. This will be about paying again. It'll start to make people think, well, actually, maybe we should be paying. Maybe we should pay for this test. And actually, the test might be there for good medical reasons, and women shouldn't be paying for them. So the budgeting is really, I think, is a bad thing. I just don't think it should be done or anything like that. And I don't think midwives should be involved in discussing that type of monetary way of paying for healthcare. That's not what we're here for. We're here to provide care for women, irrespective of the cost. I mean, there are other problems as well in maternity care, and again, they've been implemented by the government, and this is about privatising certain aspects of maternity care. So, for instance, there's one-to-one. Now, one-to-one is a private company. They have just recently gone bust. They've recently gone into receivership. Because they're a private company, they just went straight away. They as soon as they go bust, there's no warning or anything like that. So the women that they were caring for, they get no warning whatsoever. And in fact, there were a number locally here in Liverpool, the Liverpool Women's Hospital, as well as other trusts, had to kind of, come in and very quickly pick up the pieces of this private company. And what they did was they had to contact women. There were about, for example, the Liverpool Women's, I understood, thankfully contacted 300 women to, one, reassure them that they would still get care, to reassure them that actually they were eligible still for NHS care. The midwives themselves had to be provided with work, so they were given work on the bank at the hospital. And in fact, I think within crashing and within going bust, within 24 hours, the first baby that was a one-to-one baby was born then kind of back in the NHS. Now, the difficulty I think here is because, you know, these companies can look as though they're providing great care, you know, they're providing one-to-one, they're providing continuity. As far as I'm concerned, this is what the NHS should provide. And if the NHS was resourced properly, it would be able to provide that care. But what they're doing is the money from the NHS is going to this private company. The private company are using it to pay for the midwives, to pay for the care. But actually, the money is also sieved off to pay for the private company, so that the people that own that company also get money from the NHS. So NHS money, the money that we've paid in as taxpayers, or however we've paid it in, is then getting taken out of the NHS and given to a private company. So, and it was sad. It was, you know, it was sad when the company went into receivership, went bust, because, you know, women were left just completely left. They you know, were they going to get the care, and what had happened to their midwife? The midwives themselves, you know, were then without work. But I think we all need to realise that this is what happens in private healthcare. That this is, you know, this is the situation. The NHS isn't going to go bust. The NHS will never go bust if it's continued completely as funded by the government, as it were, not by private private companies. But private companies will go bust, and this is the future. If we're going to go down the road of privatisation of the NHS, this will happen constantly. That as soon as private companies don't make any money, they want out. I mean, I think that maternal death, for instance, and maternal and infant death and perinatal death, we always monitor that in maternity care. For instance, thankfully, you know, we have a relatively low. I do some work overseas, and I always kind of compare our rate with overseas. However, in the last year or so, there has been a slight increase, and that is a concern. You know, we certainly need to be watching this very, very carefully. And I would say that there's evidence to say that this is actually being caused by, as I said, the shortage of midwives and shortage of paediatricians and obstetricians. But there has been an increase. There has been an increase as well in perinatal death in the last year as well. And that is something that, you know, we've got to watch, and we've got to watch really carefully. And we've got to really start to look at this. Is why the likes of these confidential inquiries are so important, because they can tell us about what is happening around these deaths for us to be able to understand and for us to be able to put right. But when it's things like staffing shortages and capacity, you know, these are deaths that should never happen. These are deaths that should never happen in our country. You know, and you can compare say, for instance, the stillbirth rate, and you can compare the stillbirth rate in the UK with the stillbirth rate in other high-income countries, so other countries of Europe, and we do really poorly. You know, we don't compare well at all. And not only is our stillbirth rate higher than other countries, for instance, Scandinavian countries, but actually you can also look at the level that stillbirth rate is decreasing per year. And actually, in the UK, we're not doing well with that rate either. So there are other countries that are doing far better at decreasing their stillbirth rate as well. So again, stillbirth is massively related, as is maternal death, with poverty, without a doubt. The other thing that maternal death is related with is your ethnicity. So what we do know, again, from these reports, is that a black woman will have a 5 times more chance of dying in pregnancy than a white woman. An Asian woman will have is twice as likely to die in pregnancy than a white woman. Now, why are the government bringing in something like better births, when actually the government should be bringing in something to deal with this massive inequality that we evidently have in maternity care. We're doing something massively wrong. If women, just because of their ethnicity, are 5 times more likely to die in pregnancy than a white woman, it's immoral. It's absolutely immoral. It should never happen. So, that's where I think the government need to be focusing, because that's where we can make a real difference with deaths. And, we look at the migrant charges at the moment, again, completely immoral what's going on. I mean, thankfully, we've had some good news just recently from the Royal College of Midwives, and they have joined the BMA to say that actually we are completely opposed to migrant charges. So I think things are changing. It's great that the Royal College of Midwives are, behind this fight against migrant charges, because it's just completely immoral what is going on. I want to apologise for not being with you today, without a doubt. But I'm sorry I can't be there. But I know I know today will be a fantastic event. And I think to have shared a room with Professor Wendy Savage, I would have, loved to have spent time to listen to her talks, also the other speakers, because I think the event is about bringing together great campaigners, great health campaigners, activists. I'm looking at you here there, Leslie, as a great activist. I'm hoping there'll be clinicians there. I'm hoping the midwives are in the room today. I'd have been there as a midwife. And I think us all coming together is fantastic, because we've all got our different experiences and our different skills. I don't know about me as a midwife, but I could say that, maybe midwives, I don't know, I might be shot down for this, but aren't the greatest of campaigners, and maybe they're not greatest of activists, because I think we've got our experience and skills maybe in other areas. But to have non-midwives fighting and being activists on our behalf, I think is fantastic. And this is where, a real strong socialist, caring movement comes together for the better and for the great of everyone, whoever you are. So I wish everyone a great debates today, and coming together, supporting each other, and seeing how we can stay together and become friends and move on, basically, and make it better for women, to stop these mortality events, babies dying, mothers dying. It's about us coming together and saying no more.